Welcome, welcome, welcome. When you hear the words clinical trials, what comes to mind? History, mistrust, uncertainty. But now here's the truth. Diseases like prostate cancer continue to impact men every day, and research can save lives. So, what protections exist today? And what should every man know before saying yes or no to a clinical trial? This is a conversation we're having on the podcast today. Stay with us. Don't miss it. We'll be right back.
So we have a confirmation with a second opinion that he definitely has prostate cancer.
Welcome back to If You're My Brother's podcast. This is a podcast we created to break the silence around prostate cancer. And I'm really excited about our topic today. This episode, by the way, is part of our Black History Month series. So we're real fortunate to have a very special guest. I'll be introducing her in just a second. I'm Reggie Hicks, your host, and welcome to everyone watching on YouTube, Facebook, LinkedIn Live, and also to those listening on your favorite podcast platforms. We want to invite you in and also ask you to share, always subscribe, and engage with us. It's so important that you do so. Before we bring our guests on for today, I did want to say to everyone that are watching about PSA and the PSA anticipation, because I went through that just a couple of days ago. So just an update for those of you who may be tuning in for the first time. I'm a prostate cancer survivor. If you go to our website, ifyou'remybrothers.org, you can get out my full story. But I was a survivor and I had my prostate removed. Everything was okay until about a year ago when I had what they call a biochemical reoccurrence, which means that prostate cancer had returned. That's how I kind of interpreted it. Now, PSA was gradually going up. I ended up doing 37 treatments of proton therapy here in Atlanta. And every 3 months since then, my PSA is checked. And thank the Lord, it was undetectable once again. So I just want to say to men out there, particularly survivors or those who've had treatment and you're kind of holding your breath every time you're looking to get your PSA, that it's going to be okay. And even for those who maybe not have yet gotten treatment, but you're waiting for that PSA, is it going up? Is it going down? What's it doing? I know how it is. I know going to my chart, or some men I talk to say they won't even go to my chart. They'll just wait till the doctor comes and calls them or somebody reaches out. But I go to my chart and, you click on that button to see what the test results are. And it's always anxiety. But I'm happy to report that I'm still undetectable. And I continue to pray that that's what happens the next 3 months. And it also, I continue to pray for you, if you're going through this, that you are undetectable as well. Now, enough about me. Joining us today is Dr. Monica Webb Hooper. Now, she's the acting director of the National Institute on Minority Health and Health Disparities at the National Institutes of Health, NIH. A lot of us have heard of NIH, I'm sure. In her role, she brings international recognized expertise in translational behavioral science and clinical health psychology to the Institute's mission of advancing research on health disparities and developing effective interventions in community and clinical settings. Now, with deep expertise in public health, culturally specific behavior change, and clinical research inclusion, she offers both scientific insight and what I want to hear tonight is some practical guidance to this important conversation. So without any further ado, we're going to bring her in. Doc, thank you so much. You were in our digital green room, and as our producer Danny said, hopefully you didn't avail yourself of too many of our digital cookies.
They were delicious. They were delicious.
So I just want to thank you for being a part of this conversation. I'm really interested in clinical trials. I will tell you, just to give you a little background, that part of my journey was with my fraternity brother. I'm a member of Alpha Phi Alpha, who was diagnosed with prostate cancer, pretty aggressive. And I ended up following him around and doing a documentary around his journey. And 2 years in, I was diagnosed. So I became a part of the documentary as well. But one thing that Ralph always said was, and he was part of a clinical trial towards the end, he would say that he felt that research was like a stepping stone. He was going across this river called cancer, but if he could get from one stone to the next, because of research, maybe he could get to the other side. And so that kind of stuck with me. And I've been about the science ever since and trying to understand, not just trying to understand it in a practical way, but also get the word out to men who may be in families and folk who are watching this and have watched subsequent episodes about how important it is. Now, when people hear the term clinical trials, a lot of history and mistrust often comes to mind. What would you say are the biggest misconceptions that people still have about what happened, particularly historically, when it comes to Black folk? It's always about the Tuskegee experiment.
Right. Well, Reggie, first, I want to start by thanking you very much for the invitation to join today. I'm really honored to speak with you on this really important topic. And I want to say I'm delighted to hear about your test results and where you are in terms of monitoring your PSA. That's huge. And as a psychologist, I can certainly understand and appreciate the anxiety that comes with waiting to find out the results. So I'll pray for you and hope for the best going forward. I'm fully aligned with the thought that when people hear the term clinical trials, there's a lot of history that's involved. There's a lot of mistrust that comes to mind. When you talk about misconceptions in particular, I think there are many things that might be misunderstood about this. And one of those is that I'll be experimented on if I participate in a clinical trial and there'll be no protection for me. And with that, I would say that, modern clinical trials are tightly regulated and they are reviewed by independent ethics boards. They're monitored very closely for safety. So this fear is emotionally real, but it's factually a bit outdated. And we know that informed consent is the foundation of clinical research. So it means that you receive complete information before you participate in the trial about all of the potential risks, the benefits, and of course, your participation is entirely voluntary at every stage. Another misconception is that, I might not get anything. I might just get a placebo. So I might not even get the treatment that is being tested. And, in cancer and in many other serious conditions, ethical standards for most modern clinical trials ensure that there is a comparison against the best existing treatment. And that's known as the standard of care. So there are, 2 or more different interventions or treatments that are being compared. You don't know which one you would receive. You might receive the new treatment that's being tested, but at the minimum, you receive the standard of care. So you would never be left without an existing treatment option. And that's also a great question that if somebody is offered the opportunity to participate in a trial or they seek a trial on their own, and when they're gathering information about it, that's one of the key questions that I think they should make sure to ask about, just to make sure that they understand, what the treatment options are and how the randomization might go.
Yeah, because I think when I talked about my fraternity brother, Ralph, that's what happened to him. He was in a clinical trial that had a placebo and he ended up getting the placebo. But because of his cancer was so aggressive, I think they actually may have given him the treatment as he but even with the standard of care, he was getting, he's getting worse. Is that the normal sort of protocol for clinical trials to have a placebo, or is that at a different stage in clinical trials, or are there different types of clinical trials, I guess is what I'm asking?
Well, there certainly are different types of clinical trials, but where humans enter the picture, we're talking about, phase 2 and phase 3 clinical trials. And at that point, there's been pre-work conducted in those early phases of the clinical trial process that would have confirmed the safety of introducing a drug or a treatment into a human. And so at this time, I'm not sure when he participated in a trial, but I think it's rare for a trial to not include a standard of care as a comparison group. So it's sort of testing, is a new treatment better than the standard of care for a given illness? In this case, we're talking about prostate cancer. So just that someone would get a placebo, no medication at all, or just watching and waiting, that is relatively unusual today. But it's a question that I would, when you talk about practical advice, I'm a huge advocate for ask every possible question so that the concerns that you have are addressed and you can make an informed decision about what's best for you as a patient, as well as your family and affected people in your life.
Yeah, this happened about 12 years ago, I think. And I didn't know the details. I do know that there was a placebo involved. So I asked about the different types, but there are clinical trials that don't necessarily use a placebo. Is that correct? Or how does that work? I mean, do you have like two different types of treatment, or is it always a placebo?
It depends on the kind of clinical trial and what the purpose of the trial is. So, if we're talking about treatment trials for cancer, giving a placebo is not ethical when there is an effective treatment available. But some trials might be, something that is a behavioral trial trying to look at behavior change or lifestyle changes in cancer, for example. Or there might be trials that look at things like medication adherence or attendance in care. So there's a number of things that a clinical trial might be examining in terms of how do we change behavior or change health outcomes. So it does depend on what the purpose of the trial is, and that would determine the design and the different groups that people might be randomly assigned to receive. But if we're talking about a treatment to treat and potentially cure a cancer, you're not going to see a placebo in that case.
So let's talk about prostate cancer and from the perspective of men, particularly men of color. I mean, but any man, we don't like the doctor, except my wife says that my toe hurts. I'm going to the doctor. I'm right. I don't mess around. I'm like, I'm gone. Yeah, she doesn't though, but I'm like, I'm going to the doctor. So how do we get around the participation issue? And is that still a struggle, particularly when it comes to diverse participants in clinical trial? Is that something we're still dealing with?
We are, although I think that there's been significant improvement when we look at, for example, the National Institutes of Health and individuals who participate in NIH-funded clinical trials. The proportion, if you're thinking about Black people, roughly across all kinds of trials, so I'm not talking about cancer trials in particular, kind of approximates the proportion in the population. But there is still a struggle to enroll participants in trials. And I would say that the clinical trial enrollment, it's very important that there are participants from a variety of backgrounds. It's an ongoing challenge, especially in some areas that we really have to address directly because research that doesn't include all populations may not fully benefit all populations. And here's what is at stake scientifically in the topic of prostate cancer. Black American men are, as you know, more likely to develop prostate cancer than men of any other racial category. And so much more research is needed to understand and address the high prevalence of prostate cancer in Black men. And this remains one of the most important unaddressed health disparities in the United States. And I think a primary reason that this issue persists is rooted in challenges that I think happen at more than one level. If you think about it at the individual level, it might be because people are unaware that a specific clinical trial is even being conducted or have difficulty or just lack of awareness about how to find a clinical trial. And maybe someone might not even be eligible. Not all trials are available in every community. Of course, there are also individual concerns about, being somebody's guinea pig. And then at the systems level or the level of the scientists that are conducting the trials, sometimes these studies may not be conducted in ways that resonate with patients, or they may not be accessible to all communities. And whether that's due to lack of community engagement, trials not being designed with all populations or specific populations in mind from the outset, or maybe because they have really complex protocols. So I think a really big part of the issue with the lack of enrollment among Black individuals that actually seems to be less recognized, but I think it's actually pretty simple, is that nobody asked them, plain and simple. And when I worked in university settings, I used to say all the time, if you want more Black people to enroll, first, ask us. And second, make it make sense for us. When I think about this topic and talk about it, I think we need to approach it a little bit differently. We need to increase the focus on why individuals do enroll in clinical trials, because contrary to the myth, Black Americans do in fact participate in research. My own research program on health behavior change and disease prevention has shown this for a long time, the work of many others. We would not have a national institute on minority health and health disparities if we couldn't get people to participate in the studies. So it's interesting, though, that the reasons that patients do participate in clinical trials are actually researched less frequently than, studies that look at the obstacles or the barriers to participating. And these are things that we can address. So things like people have positive staff interactions, if there are research staff that reflect or understand the community, if the protocols are simplified, if the flexible schedules are possible, convenience. Of course, access to cutting edge care is also a reason when people find out that they could get access to cutting edge care. There's no cost for the medication or the treatment if you're in a trial. And the opportunities for frequent monitoring and follow-up care, people want that. You're going to have follow-up if you're in a study. And it might be easier to access that frequent monitoring than if you weren't in a study, actually. And I think also when people learn that they understand that there are research protections to assure patient safety, those are all reasons that we find that people do participate in trials. And of course, when we're talking about these biomedical trials, safety, few or minor side effects are very important considerations. I want to tell you about one study that's related to the question that you've asked. There's a study funded by the National Cancer Institute, which is the largest NIH institute, and it really gives us a powerful look at this issue. So they followed men with prostate cancer and identified that eligibility itself was a significant barrier. So only about 22% of the men in the study becoming potentially eligible for a trial. But they also in this study tested a solution for maybe a communication gap that exists. So they provided men with a simple, what they called a question prompt list, which was like a conversation piece with questions that they could ask their doctor. And they found that the impact of just that conversation piece was dramatic for the Black men who received it. And then they found that the clinical trial invitation rate jumped to about 80%. And I think that's a powerful finding, right, on how we can improve this process of getting men into trials. And alongside of that, there are other challenges that need to be addressed. But in terms of just entry into the trial, it's one example of how research can point us in directions of practical strategies that could be implemented in a variety of settings that give people the awareness, the agency, the communication that is needed to make decisions mutually with their doctor.
Yeah, and you kind of covered one of my follow-up questions, and it sounds like it's not necessarily a matter of hesitation, but maybe more access. I mean, if you weigh the two, are they equal, or would you say that we have more work to do on access as opposed to men being hesitant to do this? And I say that because in my mind, I'm thinking that the Tuskegee experiment, that we've aged out of that, but I'm not sure if that's the case or not when it comes to clinical trials these days. But for me, I mean, I was involved in several. One that didn't really have me to take anything or do anything other than when I had my prostate removed, it went to a tissue bank and became part of a national tissue bank for research. And I was also involved in a clinical trial that dealt with, I think it was photodynamics when it came to treating just a portion of the prostate where cancer showed up. And I enrolled in it. And unfortunately, it was not funny, but one of the criteria, you had to have another biopsy. I'd had one that showed cancer. When I went to have the second one for the clinical trial, it came back negative, which was great news for me. I was like, wow, it's like nothing showed up. And so I did not qualify for this particular clinical trial. And it was through my doctor's office. And unfortunately, my third biopsy showed that there was cancer that was still there. But I didn't really even think about Tuskegee in my decision. And is that still something that we're still dealing with?
So there's mixed views on this, and there's the studies that have looked at this exact question you're asking about, is Tuskegee top of mind, particularly for Black patients or Black people who might participate in a study? And it's sort of mixed, where some investigators have found when asking these studies, this question in the context of a focus group study or some other survey type study, and some find that Tuskegee is really not an issue that is making a determination for people about whether they would participate in a trial. We do know that Tuskegee Study, which is the U.S. Public Health Service of untreated syphilis at Tuskegee, it's one of, hands down, one of the most infamous examples of institutional betrayal And it has fueled deep distrust in science and healthcare, particularly among Black Americans. In the research that I've conducted, so I worked on a study where we were looking at the issue of community trust in a predominantly Black community in the Midwest. And we went out and we conducted listening tours in different neighborhoods to understand factors that might be associated with participation in clinical trials. Tuskegee did come up. Tuskegee came up in almost every session. Someone mentioned it as something that was important or something that they thought about. But I don't think it necessarily reflected their willingness to participate in the trial if the researchers could demonstrate trustworthiness and genuine engagement had occurred with the people who might have the least confidence, and if there was clear value of the research for the individuals. But we can't ignore that this kind of skepticism, which is very valid, has created mistrust or unease for many individuals.
You say trustworthiness. How do you show that when you're dealing with someone who is thinking about a clinical trial, particularly when it comes to people of color?
Yeah, trust is one of those fragile, underappreciated psychological constructs that you really have to earn. And once it's broken, it's very difficult to repair. And when I think about it like that, institutional distrust, in this case about science and trials, is not really too different from repeated betrayals in a personal relationship. It's just on a larger and an intergenerational scale. And I think my view is that it's really up to those with power and authority who are conducting the trials to take concrete actions for improvement so that the biomedical institutions, universities, healthcare systems, that they actually hold that primary responsibility for addressing distrust. And they can do things like publicly acknowledging the historical wrongdoings that have contributed to distrust, such as Tuskegee Syphilis Study and others. They can then outline tangible steps that they would take to ensure that these violations never happen again. And I think that there's been major grassroots effort that really started at the grassroots level because of Tuskegee and other studies that really were the direct catalyst for establishing principles that we use now to specifically ensure that everyone's rights and safety are the absolute top priority. So I think that the system can demonstrate its integrity. Processes like informed consent would ensure that everybody is fully informed partner in this, and also reinforcing that we do have multiple layers of independent oversight that we require for all research in this area. And, but honestly, Reggie, building trust is, because it's so fragile and it's been broken, it will require really hard work, and showing that trustworthiness, genuine engagement, transparency with the people who we want to participate in the studies.
And just one more question on this. I'm just curious, in your mind, how far did Tuskegee set us back when you talk about people of color in clinical trials? We missed a lot. I mean, I would think that people, after it happened, for a long time, really there was distrust. I would also say that there's probably some limited access as well. But as people started to say, okay, we need to engage other folk and make sure we get a cross-section of people in these clinical trials, I would imagine it set us back some, huh? Where people just said, no, I'm not doing that.
Yeah, a setback is an interesting question. And I don't know that I have the exact answer to how far it set us back. I do know that it damaged relationships, and that for many people, especially closer to the time of this study finally coming out and everyone learning what had actually happened over a 40-year period, there's just no way that didn't create damage. I think on the positive side, what we've seen is improvement. We've seen progress. And in my own research, which really largely focused on addressing minority health topics and health issues and working a lot with Black Americans in various studies, I didn't have problems recruiting people. But I think that's maybe because of my own experience and kind of having an understanding of what would be needed. Some of my colleagues who are not part of the community definitely have struggled more with doing that. But I think overall, when people see, and this is what, like, I think about our studies, and we talk to people in communities about what would be needed for them to even consider participating in a trial. And people said, I don't care how much you know until I know how much you care. And so if there was a genuine desire that people could observe and feel that energy to build and maintain a trusting relationship, that is very helpful. Also, if the recommendation, this has also been found empirically, it almost depends on who's referring you to the study. And trusted voices, trusted messengers. So if people are getting a recommendation from their trusted doctor, someone who they believe has their best interest in mind, someone who they've worked with. That's important. If there are leaders in communities who also maybe have public health expertise or experience, or they work closely with physicians and academics conducting clinical trials, and they say this is something that you want to consider and they trust you, then that's also something that's very important in terms of encouraging people to even consider doing this.
So you had mentioned before about finding out about clinical trials. How do we do that if we're interested in really becoming a part of a clinical trial? I mean, I've ridden the train here in Atlanta. I've seen some stuff up that says, hey, if you're this, this, and this, call this number and we're conducting a clinical trial. And also I wanted to ask too, I know some people sometimes think that clinical trials are sort of the last option. I've run out of options of treatment, so now I'm going to the experimental route. But there are also clinical trials where people are needed who are not necessarily at a particular disease or that may be healthy. So how do we find out? How can we get involved on both ends? Someone who just wants to make a difference, or someone who maybe is saying, I'm kind of, at the end of treatment options that are available, maybe I need to do this, if only just to help others.
Yeah, I think I'll answer the second part of your question first. That is one of the misunderstandings, is that trials are for people who are out of options. And you're correct that many trials are for people with either early stage of a disease or healthy volunteers. And some of those trials also provide access to cutting edge treatments that might not be widely available. Or there's studies on the prevention side of things. And that's usually where my own research fell. So I want to understand maybe risk factors for a disease, things that people can do if they change behavior. I did a lot of work in tobacco cessation and weight management, things that people can change to hopefully prevent the onset of a disease or diagnosis. And for that, we wanted healthy volunteers who may be at risk for a future chronic illness. So you're right that it's not only for people who are out of options. In terms of how do you find out about clinical trials, I would encourage going to, I guess, a couple things. Clinicaltrials.gov, www.clinicaltrials.gov, to find out what trials are going on in a variety of spaces or kinds of diseases. You can certainly look for prostate cancer studies on clinicaltrials.gov. More specifically, someone could visit cancer.gov/clinical trials. So www.cancer.gov and then /clinical trials. And then for people who'd rather speak with someone directly, they could call 1-800-4-CANCER and speak with a trained specialist who could help identify possible trials in their area.
What questions should every man feel comfortable asking? They're interested. We talked about what kind of clinical trial is it? Is there a placebo involved? What are some of the other questions that once we decide, hey, this might be something I'm interested in being a part of?
I think, and especially for men and for Black men, I speak a lot to Black men in my personal and in my professional life. And, I think my thought is that first, we need to get men into regular annual visits with their primary care, and that they really should not skip those visits, and they really should go, and they would need to have all the labs done, all the blood work, and so that they make sure that they're staying on top of their health. And, sometimes we have to push men to make sure that they're staying on top of it. But that is critical because this is curable, especially if it's caught in the earlier stages. That's very important. The other thing is, I think it's really important that we are active in our decisions that affect our health. Absolutely critical. It's your health. And you want and you need to do everything you can to preserve it. So for patients, in addition to the regular checkups in the labs, when you see a clinician, you want to be your own best advocate, ask questions, make sure you understand what's being said. I find that a lot of patients, and in psychology, in health psychology, we go in after someone has spoken to their physician or their nurse practitioner. And I would often find out that particularly Black patients, but many patients actually did not understand what was being said to them. And certainly as it relates to something like cancer, for many people, as soon as the doctor comes in and kind of matter-of-factly tells them that they have this cancer diagnosis, for the patient, that's where the conversation stopped. They don't hear anything else that's being said to them beyond, you have cancer. So it's important that they make sure that before they allow that provider to leave the room, that they understand what's being said. And they also want to ensure that they are, to the extent possible, having culturally competent care, someone who understands them. And then I would also always suggest that people should bring someone with them. Bring a family member, a significant other, a friend, especially if you have somebody in your life that has any medical background at all. Come with you to the appointment, someone who can also serve as an advocate, because many of the patients are stressed, they're anxious, they're depressed. You need someone there to help you take notes, help you ask questions. And then, of course, you should also do your background research in advance on things that you will want to ask, and that you can find online. But with that, you have to be very careful that you're only going to reputable sites, like not just, don't go any random place. You need to make sure you're going to reputable sites, National Cancer Institute, those kinds of places where you know that you're going to get evidence-based information. But it can be helpful to kind of come in with some baseline level of knowledge so that when people are speaking to you, it's making more sense because you remember reading about that, or having someone talk to you about that in advance. But taking an active role in your health is really critical, and it means just being informed. That's the way that you can make the best decisions.
Yeah, I remember it's so right. When I was diagnosed, having followed my fraternity brother Ralph, and we had the same urologist, so I knew the procedure. And after my biopsy, we were set up to record. As a matter of fact, what you see at the beginning of each podcast is when the doctor actually says that I have prostate cancer. But I knew I took I had 20 seconds, 30 seconds to kind of get myself together. My wife was there with me. And of course, we had a videographer there for the documentary, and they had no idea. But when he came in with a folder on his arm, I said to myself, oh, he's got all the treatment options and all the information. And it was kind of a giveaway. It's like, okay, I know what's coming, because before, when I was going through the clinical trial or trying to get into the clinical trial and there was no cancer, he came in with a sheet of paper. So I mentioned that to him. I said, next time you might want to hide the folder or something. But here's the thing. When he said that, even though I knew what was coming, I had been involved with Ralph's treatment and all of this for 2 years. When he said that I had prostate cancer, you're right. All I heard, I tell people, it was like grown-ups and the teacher on the Peanuts cartoon, where when they talk, he goes, wah, 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 wah. That's all I heard after he said it. And I was blessed that, my wife was there and she was taking notes. The same thing with Ralph. Ralph's wife, Joyce, was always in the room. She was a school teacher. She always had a notebook. She was always taking notes. And Ralph was kind of trying to take it all in. But you're right. You can't. I mean, emotionally, you're pretty much somewhere else when you're going through this. So that's really important if you could have somebody there with you. Now, and I have a question, and you're dealing particularly with Black men. And this is my question. Why are we knuckleheads when it comes to I want to be real. What is wrong with us? I don't know. It's and men in general, we're just knuckleheads.
You want to get me in trouble. I mean, nothing's wrong with you. You're amazing. You're all amazing. Nothing is wrong. It's just that, for some people, it is fear of finding out bad news. For some people, it is making the time to actually go in. And especially if you feel good, you feel healthy, you don't think anything is wrong, you may not understand the importance of those kind of silent things that could become a major issue, even something like high blood pressure, hypertension, that you wouldn't necessarily be able to just detect very easily. So I think for healthy people, they just sometimes don't make the time to go. And that can result in some delayed care and delayed screening, which can really make a big difference. So I think we need to make sure, especially in families, that we're talking about health. And I find sometimes in Black communities, I don't want to stereotype us because we are very diverse with what's going on in our families, but in many cases, there is a hesitation to talk about health and to talk about health problems. Sometimes people kind of keep things quiet, even if there is something going on. And so not delaying is really important. If something seems off, so there's a change in anything about your functioning, your bathroom habits, or, anything seems different, you're urinating more often than normal, something seems different, people need to kind of really try to be in tune with their body. Just like if you can tell that you might be developing a cold because you start to get a scratchy throat and you say, wait, something is going on. If anything seems unusual, it's important that we are following up and seeing the doctor. Like you said, I stubbed my toe. Who can I talk to about that? And I do want to go back to the other question you asked, because I realized I didn't say probably enough when you said, what other questions should people ask? So part of that advocacy for yourself is asking, what do I need to do to be as healthy as possible? Asking your provider, your clinician, what specific concrete suggestions they have for your health condition so that you can maintain the best possible health. Sometimes I've even liked to phrase it as if you were talking to the most important person in your life, your mom, your dad, your spouse, what would you want them to do? How would you want them to handle this? And that way, hopefully you'll get some answers. You'll take notes on what is stated. And to the extent possible, you need to follow up. You need to follow up and actually try to implement what is indicated. That's difficult for many people. So other questions that can be asked are about what resources does the clinic, the health system, the hospital have to support patients in addressing whatever their health needs are. If somebody needs to lose weight, does the healthcare system, do they have any options there to assist with weight management or weight loss? If someone needs to quit smoking, do they offer a smoking cessation program? If someone's depressed or anxious, do they offer social work or psychological services to assist? Because it requires a holistic, whole person approach to dealing with health. It's not just that someone has, in this case, we're talking about prostate cancer, but it's not just that someone has this diagnosis. As you're talking about, that affects everything else going on. That could affect their employment. That could affect so many things. And so talking with the health systems, which they often have ways that they can provide wraparound care and services to kind of support all of the needs that a person would have. If they need to change their diet, a high intake of dairy or calcium might actually is associated with a slightly increased risk, although the evidence there is mixed. Obesity is linked to more aggressive prostate cancers. So there are things that we need to know. Even if someone has a diagnosis of cancer, even if it's at a later stage, there are things that people can do to enhance their longevity and increase their odds of going into remission with treatment. So they need to know, what do I need to do? And then figure out how to implement those things.
Yeah, I noticed that in doing this podcast and just talking to men in general about not just their overall health and also about prostate cancer and knowing your PSA. And of course, a lot of even family members don't want to talk about the heredity part, or is prostate cancer prevalent in the family? Older people say, yeah, well, he has some issues down there, because it's kind of like nobody wants to talk about what really happened. And I think Ralph found out that prostate cancer was pretty prevalent in his family health history, but he had no idea, no clue until he started asking around. And even then, it was really, really hard to get people to talk, to bring it out. Now, what I've noticed, and I don't know if you've seen this, I've noticed that in a lot of the Facebook groups, men are very open. I think you can have anonymity, but I noticed that men are very, very open to men that I know that have had prostate cancer, that I know that have had treatment, that are close to me, won't open up about, talk, how are you doing? What's going on? How's the incontinence? I don't know. I don't even get into the ED part because, I'm pretty transparent. I just noticed that there seems to be a lot more when you look at social media, kind of open. But as I talk to men, any ideas you can give me to kind of break down some of those walls when I'm out there and as a psychologist? Or should I just talk to me? What's wrong with you?
Well, I mean, of course, the approach matters. I mean, I think, and I've observed this too on things like Facebook groups and other groups where people can share with people who they don't know. They are willing, and somebody will post a question. How are you all dealing with this? Or have you heard about this? And then there are sometimes hundreds, thousands of people commenting, depending on the size of the group, about an issue. And there is evidence that social media can actually serve as an intervention forum. The challenge, though, is making sure that you are getting the right information and that people are not spreading misinformation or things that are just not based on any evidence. So I would encourage everyone who is willing to communicate, if that's the forum that they feel comfortable, that's fine. You probably would hear something that sounds interesting, and you should follow up on that by, again, taking a look at what the evidence base is, going to, for example, the National Cancer Institute or another, oftentimes the federal sites have evidence-based information, or if it's one of the really well-known universities or something like that, to actually find out what the evidence actually tells us about this issue, because sometimes there'll be a grain of truth to it, but not really. So having the conversation and being willing to talk about it's important. People also have found in research that certain settings like barber shops and those kinds of, you might have seen those kinds of studies, that it's trying to essentially create a space or go into a space that maybe already exists where men are conversing and enjoying their time together. And there might be an opportunity to bring up a topic that's related to health. People are challenged sometimes to talk about things like prostate cancer because of the nature, as you said, of things like erectile dysfunction or what it means for one's manhood. Once we can help people get through that this is not a reflection of one's manhood and what that means, then that hopefully can help open up a conversation. When someone also has lived experience, so somebody like you who has lived experience, who can talk about it, and it's coming from that place of, I have personal knowledge of this and I'm willing to share, that's also very, very helpful for people to get other people to open up about the situation. Of course, I'm a psychologist, so I have to recommend that people seek care with a health psychologist. There are health psychologists like me who study behavioral medicine. So it's that interplay between mind and body. It's a very holistic approach to health. So it's not just looking at the biology of it, but the psychology of it and the social factors that go along with it. And that's also very important, can help people talk. So, and then of course, with people's significant others, if they're willing to talk about it with them, would be helpful. Waiting and not talking about it is definitely not desired.
How do you find the psychologist that maybe you can talk to? Not from me necessarily, but who knows? And I will say that, I think when it comes to people of color, they want someone who they can identify with, particularly when you're talking about feelings and the mind and things like that. So where would I go, or where would someone go if they're interested?
Well, I think for people who are in the kind of social media groups you mentioned, that would be a post. That would be a question to ask. I'm looking for, I'd like to talk to a psychologist. Does anyone know, a Black psychologist who focuses on men or who is a health psychologist? Can anyone recommend? And people will put in, oh, this is a good person. Go see this person. Or, just the same way, if you need a dermatologist, that's a Black dermatologist, you can ask that question. So that might be one starting point, just kind of socially. If someone hopefully has access to health insurance and they can look up who are the providers in the network, who are psychologists, and sometimes, you have to look and see who are the people, look them up, they'll have pictures. If it's important to you to have someone who you believe you can connect with because you have a similar racial background or ethnic background or language background, that would be another way to do that. And then, of course, just a plain Google search to look for people in your area who focus on this area. We're out there. There's not probably as many as we need, but we're certainly out there. And I would say that if it's not possible to find somebody who is available, who has a similar background that you do racially, you should still give a try to someone else who may not, because what the research shows there is that while many people would report that they would prefer a race-matched psychologist, that when they're able to connect with someone, that even if there is a racial mismatch, the outcomes are just as good if they can find someone that they can connect with.
Get someone that you can talk to.
Exactly. And who you feel is good about what they do.
So I guess we're wrapping up here, and I do appreciate you giving us the time. I know a lot of times we do this at 7 p.m. Eastern time, and it gets kind of late for people, and it's Thursday. So I appreciate you taking the time. So if you could leave our listeners and viewers with one key message about trust, research, taking an active role. We talked a little bit about that. What would it be? What would be the key message you would like to leave?
All right. So I'll think about this in terms of key message. One, I'll talk about trust, and then I'll talk about the research message I have. And so my message about trust is this. I completely understand the mistrust or the distrust that many people feel. It's based on real experiences, and no matter what anyone says, it is valid. And with that, though, I have witnessed a genuine desire to build and maintain trusting relationships among many scientists. Really, I believe them when they say they want to have true community trust. So it's important that somebody who is considering joining a trial or is invited to enroll in a trial listens very carefully with respect to the purposes and the goals of the study, that they read all of the documents that describe the study, including the consent form, and that you ask enough questions to be comfortable participating, and that you believe you can trust that your health and your interests are being protected. Your trust must be earned. And my message about research is that clinical trials really are the engine that powers medical progress. So for the NIH to ensure that new treatments are safe and effective for your sons, brothers, fathers, it is essential that Black men who face the highest rates of prostate cancer participate in this research. And it's not true that Black Americans or Black men do not participate in research. Some of my most cherished participants, who I'll always remember, who put in a great deal of effort into the studies that my group was conducting, were Black men. And it was an honor for me to have them join and to see their health improve in a short time. And we do have these really rigorous systems of protections that come from major grassroots efforts from the community that help hopefully gain trust, and many people, including our men, are having positive experiences.
Wonderful. Well, we want to thank you, Dr. Webb Hooper, for joining us, and also for the work that you do and continue to do. It really is important. And I'm hoping that those that listen and see this podcast will get involved, because it is a team effort. We all have to do our part. And I just thank you for being there for us and taking the time to talk to us this evening.
You are so welcome. It's been an honor.
All right. We want to thank once again Dr. Webb Hooper for bringing clarity and context and insight to this very important conversation. And for every man listening, this is about asking questions, understanding your rights, and taking an active role in your health. Research has helped save lives. And when we are informed, we can decide on how we want to participate in shaping the future of medicine. And we're empowered to make that decision that can protect our health and our future. So if this conversation has helped you, share it with a brother, father, son, friend, colleague. And you can also visit our website at ifyouaremybrothers.org. That's ifyouaremybrothers.org to learn more about our documentary that we're working on. I talked a little bit to the doc about that, our podcast series, and our community engagement work, which is so important. If You Are My Brothers, by the way, is a nonprofit 501c3 project of Straight Street Media. And Straight Street is dedicated to turning prostate cancer awareness into health action. It's health awareness, but it's also health action. That means doing something like knowing your PSA and knowing your PSA. Keep saying that, right? So you can support us in our efforts. We have a number of options available. And also in our show notes, you'll be able to see the link as well. Now, I always say when you make your contribution, we want to thank you for keeping this podcast on, for being a part of the documentary, and also our community engagement. But we also have I feel like I'm on PBS, which I've done in the past, by the way. So here is our wonderful mug. See, it's the If You Are My Brothers mug, and it's yours when you make your contribution in any amount. So we appreciate it. And we want to thank everyone for making a contribution and making this project happen. And also thanks to Atlanta Brand Central for providing our new mugs. Thank you very much, Daryl, for all you do. It's Atlanta Brand Central. We also have a link in our show notes to Atlanta Brand Central as well. Very special thank you to our producer, Danny Garcia Pozo, who's back there punching all the buttons and making us look and sound good. And also Zach Reynolds at Borkhouse Productions for our opening that you see on each one of our episodes. We want to thank him as well. And finally, remember, this podcast is not a replacement for your medical team. We want to always tell you, always talk to your healthcare provider for that. One other thing, I want to remind you, we talked a little bit about Facebook groups. So we're starting a Facebook group, the If You Are My Brothers Facebook group. It'll be up on the website. If you want to join us, you can also look for us on Facebook, If You Are My Brothers Facebook group. We'd love you to join and get involved in the conversation. We'll also be sharing information about future episodes and our community engagement efforts, and also what's happening with our documentary as well. So join the If You Are My Brothers Facebook group. Hope to be communicating with you there as well. So until next time, if you are my brothers, please share this message. If you are my brothers, know your PSA. And hopefully, prayerfully, we'll be back again in a couple of weeks. Thank you again for being a part of the If You Are My Brothers podcast. Take care. Stay healthy. Peace.